Good afternoon, everyone. Thank you for joining us at the California Dialogue on Cancer's Surveillance Data Webinar Series. My name is Sheila Senyo. I go by she, her pronouns, Strategic Alignment Specialist for the Comp Cancer Program and the California Cancer Registry. Please feel free to introduce yourselves in the chat with your name, pronouns, and organization, and where you are joining from. So I'll go over some housekeeping while everyone is typing in your intros. I also want to acknowledge my colleague Joy Seha, our Coalition Coordinator Specialist, who is playing a key role in today's webinar presentation production. All participants have been muted, but we will leave the chat or Q&A box open for questions. We'll also have an allotted Q&A after the speaker's presentation, so please stay until the end of the presentation to also participate in a short webinar evaluation. Again, for those who are just joining in, please type in the chat your name, pronouns, organization, and where you're joining from. The California's Comprehensive Cancer Control Program is a CDC-funded program that provides leadership and coordination of statewide comprehensive cancer control efforts. The Comp Cancer Program leads the Cancer Coalition, which is CDOC, and it's also required to develop and implement a state cancer plan. Next slide. So there have been 5 iterations of the state cancer plan, including the 2026-2035 iteration, which is California's first 10-year state cancer plan. The plan focuses on health equity and prevention to eliminate disparities and improve outcomes. It is currently in the CDPH approval process with an expected release in early 2026. So the plan will be available exclusively online. As a background information, these are the cancer plan topic areas for the upcoming 10-year plan. CDOC works closely with the Cancer Registry and other partners to implement strategies from their surveillance topic areas. So our goal is to enhance cancer surveillance systems so we can produce and share public data in ways that are meaningful and accessible to the public, health organizations, researchers, and other partners. The Comp Cancer also partners with the UC Davis CalCARES program on our various surveillance reports. So CalCARES is an acronym for California Cancer Reporting and Epidemiologic Surveillance Program. They have supported key strategies such as ensuring wider dissemination of cancer data and by producing culturally and linguistically appropriate cancer reports. In today's surveillance data webinar, a UCD researcher will present one of their published reports on childhood cancer, which is also a newly added chapter in the upcoming state cancer plan. Today's presenter, Nellie Gottlieb, is a research data analyst with CalCARES at the UC Davis Comprehensive Cancer Center. She has worked in the surveillance and data use unit for the past 2 years, providing analysis and supporting data disclosures related to cancer research with a focus on clear and accurate reporting. Please join me in welcoming Nellie.
Hey everyone, thank you so much for joining today. My name is Nellie Gottlieb, and I, as was just said, am a research data analyst in the CalCARES program at UC Davis. And I will be presenting on the burden of cancer among children and adolescents in California. Okay, perfect. So for some background, in this presentation, I will describe incidence and survival of childhood and adolescent cancer in California. In 2025, across the US, 14,690 children and adolescents were projected to be diagnosed with cancer, and 1,650 were projected to die from it. Cancer in children and adolescents is the second and fourth most common common cause of death for these age groups respectively. So understanding current incidence and survival trends in California can help monitor progress in the burden of cancer among children and adolescents, as well as identify sociodemographic disparities. More than 85% of those diagnosed now survive at least 5 years. Next slide, please. So as I said before, the purpose of this talk is to describe cancer incidence and survival among children and adolescents in California. Next slide, please. Okay, so I'll start by describing the cohort we used for analysis. So we used California Cancer Registry data with the date of diagnosis from 2007 to 2021. Everyone was a California resident at time of diagnosis. We looked at the following 17 cancer types that are on the screen. And children were categorized as individuals diagnosed 0 to 14. Adolescents were diagnosed 15 to 19 years old. Next slide, please. So the first measure that we looked at was age-adjusted incidence rates by age group. So children are on the left and adolescents are on the right. Overall incidence was higher in adolescents compared to children. In children, the most common cancers were acute lymphoblastic leukemia, astrocytoma, neuroblastoma, acute myeloid leukemia, and non-Hodgkin lymphoma. In adolescents, Hodgkin's lymphoma, thyroid carcinoma, germ cell tumors, acute lymphoblastic leukemia, and non-Hodgkin lymphoma were most common. Acute lymphoblastic leukemia and non-Hodgkin lymphoma were in the top 5 most common cancers for both age groups. Next slide, please. Okay, next we looked at trends in age-adjusted incidence rates, and this is also by age group. So children are shown in green and adolescents were shown in blue. For adolescents, incidence rates remain stable from 2007 to 2021. And then among children, rates increased from 2012 to 2015, followed by a decline after 2015. Next slide, please. Okay, and this slide, we're looking at age-adjusted incidence rates by sex, and this is for children and adolescents combined. So among males, the top 5 cancers during this period were acute lymphoblastic leukemia, astrocytoma, germ cell tumors, non-Hodgkin lymphoma, and Hodgkin lymphoma. Among females, the top 5, oh, sorry, would you go back? Yeah, thank you. Among females, the top 5 cancers were acute lymphoblastic leukemia, astrocytoma, non-Hodgkin lymphoma, Hodgkin's lymphoma, and thyroid carcinoma. Notably, 4 out of the top 5 cancers were the same for both males and females, with the only difference being germ cell tumors in males and thyroid carcinoma in female. So, overall, age-adjusted incidence was higher among males than it was among females. Next slide, please. Okay. Now we're looking at trends in age-adjusted incidence rates by sex, and for both males and females from 2007 to 2015, incidence rates increased, and then after 2015, there was a decline in rates through the end of the study period, which was 2021. Next slide. And then when looking at rates stratified by race ethnicity, rates were highest among non-Hispanic white individuals, followed by Hispanic, Asian Pacific Islander, and then non-Hispanic Black individuals. Next, please. Thank you. Across the 4 race ethnic groups that we were able to look at, acute lymphoblastic leukemia was the most frequently diagnosed cancer. Hispanic children and adolescents had the highest incidence rates of acute lymphoblastic leukemia, followed by non-Hispanic white individuals. Next, please. Next, we looked at 5-year relative survival, and this is 5-year relative survival of children stratified by sex. So, and for this, we looked from 2007 to 2021. Survival was high for several cancers, especially thyroid carcinoma, Hodgkin lymphoma, and germ cell tumors, where survival is around 98 to 100% for both male and female. However, survival is not equally high across all cancer types. The lowest survival cancers for both males and females included embryonal tumors, acute myeloid leukemia, and rhabdomyosarcoma, where survival drops to roughly mid 60 to low 70% range. And survival for children is comparable when comparing males and females. Next slide, please. Next, we looked at 5-year relative survival of adolescents stratified by sex. So similar to children, survival is very high for several cancers, especially Hodgkin lymphoma, thyroid carcinoma, germ cell tumors, and retinoblastoma, where survival approaches 97 to 100% for both sexes. The lowest survival cancers for both male and females include acute myeloid leukemia, rhabdomyosarcoma, hepatic tumors, and Ewing sarcoma, where survival drops into 40 to 60%. And also notable, survival across all sites was higher for females than it was for males among adolescents. Next slide, please. Okay. Next, we're looking at 5-year relative survival by race ethnicity, and this is both children and adolescents. So overall survival is highest for cancers such as thyroid carcinoma, Hodgkin lymphoma, and germ cell tumors across all race and ethnic groups, with survival generally in the mid to high 90% range. However, there are disparities present. Non-Hispanic white and Asian Pacific Islander patients had a slightly higher overall survival, while non-Hispanic Black and Hispanic patients tend to have a lower survival across all cancer types combined. The lowest survival cancers across race ethnic groups included acute myeloid leukemia, embryonal tumors, rhabdomyosarcoma, and osteosarcoma, where survival often falls into the 60 to 70% range. Next, please. So this is a 5-year relative survival, a comparison over 2 different time periods. The first time period we looked at was 1992 to 2006, and the second time period was 2007 to 2021. So overall survival improved substantially, increasing from around 78% to 85%. Survival improved for 14 of the 17 cancer sites, showing major progress in treatment and care over time. The largest gains were seen for Ewing sarcoma, hepatic tumors, neuroblastoma, embryonal tumors, ependymoma, non-Hodgkin lymphoma, and acute myeloid leukemia. Survival did not increase for astrocytoma, melanoma, and retinoblastoma. However, survival for melanoma and retinoblastoma was already very high at about 94 and 97% respectively. Next. So in conclusion, overall incidence decreased for children, while incidence among adolescents remained largely unchanged. Incidence rates were higher among adolescents compared with children and higher among males compared with females. By race ethnicity, incidence was highest among non-Hispanic white children and adolescents. Decreases in incidence were seen mostly in children, and the lack of improvement among adolescents is consistent with other studies that have reported increasing or stable incidence in this age group, including increases in acute myeloid leukemia. The causes are not fully understood, but possible contributors to these cancers include hereditary cancer syndromes, which may account for up to 8% of diagnoses. Adult type lifestyle and environmental risk factors such as smoking, alcohol, obesity, and air pollution are not thought to play a major role in adolescent or childhood cancers. Taken all together, these findings highlight the importance of continued surveillance and research to better understand the causes of childhood and adolescent cancers and to support prevention, early detection, and equitable care. Next slide, please. In conclusion, for survival, 5-year relative survival increased across many childhood and adolescent cancer types over time, likely reflecting improvements in diagnostics, risk stratification, and treatment strategies. Despite these gains, survival remains lower for certain cancers, particularly for male adolescents with rhabdomyosarcoma or hepatic tumors, and female adolescents with rhabdomyosarcoma or Ewing sarcoma. We observe sex-based differences in survival across several cancer types, which may reflect differences in treatment response, timing of diagnosis, and tumor biology. By race ethnicity, survival was lowest amongst Black children and adolescents, consistent with prior research and highlighting ongoing inequities in cancer outcomes. Notably, survival for acute myeloid leukemia improved substantially, potentially reflecting advances such as molecularly targeted therapies, immunotherapies, and hematopoietic cell transplantation. Overall, these findings highlight major progress in pediatric cancer survival, while underscoring the need to address persistent disparities and improve outcomes for cancers with lower survival. Next slide, please. We did have some limitations with the study that we did. So small case counts limited our ability to calculate some statistics for non-Hispanic Black individuals, and AIAN individuals were not able to be included. Because racial and ethnic disparities in pediatric cancer are well documented, future work could expand the years of diagnosis to increase sample size and allow more detailed analyses. We also did not examine the impact of sociodemographic or clinical factors on survival, which are important areas for future research. Despite these limitations, we've shown that cancer continues to pose a significant health burden to this population. And then next, please. And these are my acknowledgements of co-authors to this paper. Thank you.
Thank you so much, Nellie, for your insightful presentation on the burden of cancer among children and adolescents in our state. At this time, I'd like to open the floor for any questions or comments. Please feel free to raise your hand and unmute yourself. And I'm also checking questions on the chat. Actually, Nellie, I do have one question. You mentioned limitations due to small case counts for Black children and adolescents. What strategies could help overcome this in future studies? And are there plans to incorporate socio-demographic or clinical factors in future analysis?
Yeah, so like I said, we weren't unable to include them just because of small case counts. So increasing our years of diagnosis would allow us to include those ethnic groups that were unable to be included because of small case counts.
Thank you, Nellie.
Yeah.
Misha, I see your hand raised. Go ahead.
Thank you, Sheila. Thank you, Nellie, for first of all, for doing the work and then sharing the work with us. Really appreciate it. I have a couple of different questions, but the first one that I want to ask, like you did talk about embryonal tumors, and in general, pediatric brain tumors are the leading cause of death by disease in childhood cancer, right? So I was like, do you have any insights on the California burden for non-embryonal tumors? Because those are typically more aggressive and have less treatment options.
So we didn't specifically look at, you're talking about like survival in these groups?
Survival, or even just in terms of incidence rate, or any kind of information, because the only type of CNS tumors that I saw were ependymomas and astrocytomas. So I was wondering if there was any insights on other type of the pediatric brain tumors that have the highest mortality rate associated, and what is the distribution in California?
So we only included these sites that were listed just for the sake of the report, but that could be an area to kind of narrow in on in the future to gain more insight.
Oh, thank you. And then I think in one of your earlier slides, you showed that there was an increase till a period of time till 2023 2015, from 2012 to 2015, and then it kind of dropped.
Yeah.
Do you know why that bump was? Was it because then we got better at diagnosing, or the treatment options were better? That's why the curve dropped.
So this just incidence rates wouldn't kind of encompass treatment in that way because this is diagnostic. So, potentially it could be indicating better diagnostics, but I'm not sure what is driving that trend exactly.
And then, sorry, two more questions, and then I'll stop talking. I think the highest incidence rate was ALL in all of California. Did I follow that correctly?
Um, Let me pull up that slide for incidence.
Yeah.
So yes, it is ALL.
Do
Mhm.
we know why is that, why California has such a high level of ALL incidence rate? Like, do you know is it an environmental factor? Is it all because of hereditary, or is it because of population-based incidence rate?
I'm not sure why ALL has the highest rates compared to other cancer sites.
Okay. And the last question is, how does this compare across, the nationally, is California the highest for all ALL, or there are other, where does California fit on the national scale of childhood cancer incidence or survivorships?
Yeah, that's a really good question. We did not compare our data to national data, but that is a good idea in order to expand the analysis that we have done to compare it to the trends on a national level.
Perfect, perfect. Thank you so much, Nelly. Appreciate it.
Thank you.
Thank you, Misha, for your thoughtful questions. Double checking the chat. I don't see any other question. While we're waiting for additional questions, Nellie, is there anything you'd like to expand or add to your presentation?
No, thank you.
Sarva, go ahead.
Yeah, thank you for the presentation. I appreciate it. I'm going to follow up, or rather piggyback on what Misha said, especially for pediatric cancers like brain tumors that have and almost terminal, very bad outcomes. I think we should somehow find a way to represent it even as a separate chart or something, because if it doesn't get noticed, you don't get kind of, you don't start a conversation about it, or anything like that, right? So I think it'll be we have seen this for quite some time that those are not being included. So I think it'll be really helpful if we find a way to make sure, even if that's a separate stats or something like that, especially for some of the cancers that have very bad outcomes.
Mhm.
Yeah.
Yeah, we can definitely look at really highlighting some of those tumors and those cancer types that are um, not being looked at as much.
Yeah, thank you.
Thank you, Sarva. Nellie, I see a question on the Q&A box. Are there difference in incidence rates by geography across California?
That is also a good question and not something that we analyzed during this report, but again, something that we could look at in the future.
Thank you, Nellie. Give it another minute to see if there are any other questions. And thank you, Kimberly, for posting some of the stats.
You're welcome.
All right. Looks like we don't have any more questions at this time, so we'll go ahead and wrap up a little early and advance to our last slide. Thank you again, Nellie, for sharing such valuable insights with us today. Please take a moment to complete the short webinar evaluation that my colleague Choice have shared in the chat. Our next webinar is on April 29th, where we will hear from a presenter at CCR. The recording and slide deck will be shared with you via email. Thank you all so much today for joining, and we look forward to your participation at the next webinar. Thanks, everyone.
Thank you.